Good evening, everyone. This is Dr. Maheshwar Naidu speaking. This is our weekly online registrar tutorial run every Wednesday between 7 and 8 p.m. Today's format is slightly different in that I'm running it as a webinar. You'll see that the controls from the normal Zoom meeting are slightly different. It just gives the host and presenter a little bit more control. But other than that, you will be able to see the screen and ask questions, etc. I'm very pleased to welcome Dr. Victor Govindasamy, who is the head of clinical department at Greys Hospital in Pietermaritzburg, and he has a special interest in colorectal surgery. Welcome, Dr. Govindasamy, if you want to take over.
Okay, thank you, Dr. Naidu. Okay, welcome everybody. Basically, today we're going to speak about a few colorectal conditions. I see this as a forerunner for future meetings where we will cover probably more colorectal conditions. Okay, so to understand colorectal disease, I think it's important for you to have a proper understanding of the anatomy of the colon and specifically the pelvis. Without a proper understanding of the anatomy, it makes the surgery quite dangerous. I think for you to understand the disease properly and even to understand the procedures, it's key that you get a proper understanding. We will go through some of the anatomy in our discussion, but I think we will come to that just now. The other important thing that you need to do when you're preparing, especially for the FCS final exam, to understand what is the best option for the patient according to evidence-based practice. And I think sometimes you'll find that in a local setting, we do not necessarily adopt the best practice because we have to make a practical solution due to lack of resources. So don't accept this as the best practice. And in an exam situation, you should be aware of both. What you'll do when there are lack of resources, but more importantly, what's the evidence supports. In terms of the talk today, we'll be covering three aspects. Basically, I'll go through anatomy of the colon rectum. We'll focus mainly on colorectal cancer, and I'll touch a little bit on diverticular disease. We'll see how it goes in terms of time. If we are running quite long, maybe we will leave diverticular disease for another discussion. In terms of the anatomy of the colon, so the colon and the rectum is about 150 centimeters long. Essentially, it has 7 parts. Can someone in the audience maybe give me a quick summary of the different parts of the colon and the blood supply?
If you'd like to volunteer, there should be a button where you can put up your hand. Dr. Khan?
Hi, Mr. Naidu. Hi, Mr. Govindasamy. I'm happy to give a try for the first question. So just a quick summary of the anatomy and the blood supply. If we look at the colon and the rectum, the colon itself can be divided into the cecum, the ascending colon, the transverse, the descending, and then the sigmoid colon. And then thereafter, we can look at the rectum, which then is, if we look at it, is usually divided into proximal third, middle third, and distal third. There's also differences in the definitions of the surgical definition of the rectum as well as the anatomical definition of the rectum. Anatomically usually being referred to at the level of the sacral promontory, but surgically sometimes it's perceived usually around the level of vertebral body S2. And this obviously does have clinical significance later on. In terms of the blood supply, there's right colic artery, left colic, as well as a middle colic artery. The right colic is a branch of the superior mesenteric. The middle colic and the middle colic is also a branch of, the middle colic is a branch, yes, also of the superior mesenteric. And then the left colic is a branch of the inferior mesenteric. And the inferior mesenteric obviously continues on to terminate as, or gives off the superior rectal as well as sigmoidal branches. and does provide some supply to the middle third of the rectum as well. The inferior rectal comes from branches of the internal iliac.
Okay,
I'm not sure if that's an adequate answer, Mr. Govindasamy.
I think that's quite good. We'll just go into a little more detail. Okay, so as you can see in the diagram here, basically this is the ileocolic artery, and it's basically two parts to the ileocolic artery. One part which basically supplies the ileum, and one part which supplies the cecum. So it actually forms like an arcade, and that's the two parts to it. Then you have your right colic artery, your right colic artery there, and there's your middle colic artery. And I think the important thing to note about the middle colic artery, even though it's called the middle colic artery and it supplies the transverse colon, it's actually very much on the right side. And it actually gives off its two branches, basically your right marginal branch and your left marginal branch. And basically those form your marginal arcade of Drummond. If you come to your inferior mesenteric artery, so there's your inferior mesenteric artery, and then it gives you off your left colic artery. Right? And then it continues as a superior rectal artery and gives off several sigmoid arterial branches, and basically continues down into to supply your rectum. In addition to that, you also can get a variable blood supply, or what we call the middle colic artery, should be about there. And so your middle colic artery basically comes from your internal iliac artery, so it's a branch of internal, but that's consistently present. And then you get from your internal pudendal artery, which is down there, you get your inferior rectal artery basically originating. So in terms of arterial blood supply, that's the main arterial blood supply. But it's important to understand that blood supply can have several variations. And we'll talk about one of the other variations that you may have is a communication between your superior mesenteric and your inferior mesenteric. And basically, the original name was the meandering mesenteric artery, also called the arc of Riolan. So this is the vessel basically we're talking about here. All right. So the arc of Riolan may or may not be present. So it's present in a certain variety of the population. The other important thing to understand is your marginal artery of Drummond also forms the second communication between your superior mesenteric artery supply and your inferior mesenteric artery supply. Other relevant relations that one needs to focus on is what we call Griffith's point, Sudeck's point, Gruber's fold, and Tol's fascia. So Griffith's point is basically referring to the point and Sudeck's point where your blood supply can be quite tenuous, and often we call them the watershed area of the colon. So the splenic flexure and the sigmoid colon. With regard to Sudeck's point, basically it talks about the point at where the last sigmoid artery comes off the superior rectal artery. And at that point, basically there is where your blood supply is probably the poorest. And that's generally why when you do sort of a sigmoid resection, you would try and obviously make sure that you resect it completely and you don't do a segmental resection of the sigmoid. And Griffith's point basically is because his communication of the marginal artery of Drummond is not consistent, that can lead to basically flow of blood supply to the splenic flexure. Even in a situation where you have trauma, for example, to the sigmoid, to the splenic flexure, one must think very carefully before you actually do an anastomosis or repair at the splenic flexure. So now, Gruber's fold is something you probably haven't heard about. So this is a fold that's demonstrated when you retract the sigmoid colon basically laterally and inferiorly. And it's actually formed by your superior rectal artery. That's a superior rectal artery. And so it's a fold that's formed by the mesentery of the sigmoid colon. It's very important for laparoscopic surgery in that it allows you to identify where your superior rectal artery is and to identify the plane between the aorta and the superior rectal artery. because this is the point at where you will initiate your laparoscopic dissection. Now, Charles fascia, we all know about the Charles white line, the lateral line that's basically where the peritoneal has fixed the colon down to the retroperitoneum. Actually, Charles line is probably not very important. I know we are often told to dissect in that, but basically if you just go lateral to the colon, you'll be in the right plane. So when you're doing open surgery, especially on the left side, it's important to dissect in Charles fascia. So you can see Charles fascia is basically this plane here demonstrated by this blue arrow coming from the left-hand side there. All right, so that's just immediately behind the colon itself, and also the mesentery of the colon there on the sigmoid or the left colon. When you do laparoscopic surgery, you tend to actually go a little bit more posterior, and that's mainly because you need to get behind the blood supply of the colon. So actually you'll find your artery here actually, which is your superior rectal artery probably, leads you to just go a little bit more posterior. So you may not necessarily be in that complete avascular plane that you should be, but at the same time you obviously cannot go too posterior. So if you find that you actually showing the ureters with no fascial covering over it, or even the gonadal vessels, then it means that you're too deep basically in your dissection. So I think open surgery especially, and I'm sure most of y'all will be doing open surgery, important when you're mobilizing the left colon to basically find that plane between the colonic mesentery and the fat of the colonic mesentery and the fat of Gerotis fascia. You'll see there's a subtle difference in the lobules of fat and even the color of the fat itself. And that's how you can demonstrate the difference. So next time you're doing a left colonic mobilization or right colonic mobilization, try and make sure you find the right plane. So once you do it once, it's very easy to repeat the process. Okay, and it's important to dissect in the correct plane and not damage other structures. On the right side, as I said, the same plane is present, and it's the same principles. All right, so as you can see, that will probably be your retroperitoneal structures like your psoas and all of that, and your ureter and all lying posteriorly. But behind the actual mesentery, there's this plane, right? And in this case, they call it the colofascial plane, but that's Charles fascia basically there. Okay. So it's important on this side also to have that same dissection. And we find often when you mobilize the right colon, especially if you start inferiorly, you end up actually going too posterior and you end up behind the kidney. So I often advise a lot of the doctors that train with me that ideally you should mobilize from the hepatic flexure downwards. And that's probably the easiest technique to find the correct plane. And I think once you're more experienced, then you can practice doing it from inferior to superior. And when you can identify the anatomy of it better. So I think these things, that anatomy is critical to doing proper colorectal surgery. And when we discuss some of the new advances later on, we'll find why it's important. So colorectal cancer basically is the third commonest malignancy worldwide. The lot of literature from overseas suggests that there's an increasing trend in terms of right colon cancers increasing and a slight decrease in left colon and rectal cancers. But as I say, this is literature from the first world, so it probably doesn't represent any part of Africa. It doesn't represent us in South Africa at all. Okay. Whenever patients present with symptoms of colorectal cancer, it's usually very suggestive that these patients actually have advanced disease. And if you can identify it when the patients have very mild symptoms or actually asymptomatic, that's probably the ideal thing. I mean, that's why overseas they have screening programs for this, because their population obviously lives to quite an advanced age, and the incidence is much higher in the 70s and 80-year-olds. So in terms of the presentation, is there anyone who can maybe give us an idea about how colorectal cancer presents? Maybe a few of the symptoms and signs? Maisha, you nominate somebody? Hello? Is anyone there who wants to give us an answer for that, please? Maybe a quick peek of the symptoms. Okay, doesn't seem like
Hello.
anyone's very keen.
Hello.
Hello?
Yes. Sorry, it's Raymond BOA speaking.
Oh, okay. You can go ahead.
Yes. So basically, the presentations for these colorectal cancers depends on which side it's the malignancy, left or right. But essentially, like generally, they do present with firstly, there's change in bowel habits. They could have tenesmus, urgency, and frequency, as the case may be. Then in very advanced situations, they probably also might have, if it's on the right side, basically, they might present with a melena, while on the left side, they could actually present with severe hematochezia, and sometimes presenting with also severe anemia or anemia, as the case may be. Also, they may present with bowel obstruction, depending on where this lesion is.
Okay, thank you, Raymond.
Yes.
Okay, so like you say, it's important to distinguish between right-sided versus left-sided tumors. The right-sided tumors, the majority of these patients probably will present with actually anemia. And the time for us to identify these tumors actually when they first present with anemia. So we generally do a lot of colonoscopies for anemia, and obviously majority of patients will probably have no findings. But if we do identify a few cancers, then that's probably the best chance of detecting the cancer early. Because alternatively, right-sided cancers will present with obstruction or a mass. And in both those cases, the tumor is going to be advanced. So I think anemia is critical. In terms of having melena, I would say generally that doesn't occur. Maybe a rare case to have bleeding or profuse bleeding from a tumor, but most tumors don't really bleed rapidly, they bleed slowly. So unless they distal, then left-sided tumors will present with rectal bleeding. And as you say, change in bowel habits, that's a predominant symptom or predominant presentation. And I think if you have change in bowel habits and rectal bleeding, the chance of having a colorectal malignancy is in the region of 80 to 90%. So definitely, if you get that history from a patient, that patient should have some investigation done urgently. And tenesmus, obstruction, and mass, basically all will suggest probably a fairly advanced tumor. In terms of understanding the pathology for colorectal cancer, also important to understand that we're basically grouping together a whole host of different diseases. So even though they're affecting sort of one similar area of the anatomy, actually right colon and left colon and rectum, the cancers that occur in those areas actually have different pathological sort of entities and probably are completely different diseases and related to different sort of changes or alterations in the genetic makeup or genetic predisposition of the individual. So I'm sure all of you should be aware of what's the right colon, but basically going up to the proximal 2/3 of the transverse colon and left colon from there up to the rectum. In terms of what constitutes a rectum, like Dr. Khan said, the rectum is not a sacral promontory. And I know lots of surgeons actually like to say, oh, the rectum's at the sacral promontory. And it actually starts at the junction of S2 and S3. And so the rectum is actually much lower. And sometimes we tend to classify high tumors that are probably in the distal sigmoid colon as rectal tumors, and we shouldn't be doing that. There's a good article in the Annals of Surgery from December of 2019 on this, and there's an international consensus on how to define the rectum. They propose using the MRI for this, obviously not freely available with us, so we can try and use what tool we have available. But obviously try and make sure that you identify where the tumor is so they can get the ideal treatment, basically in terms of whether they need chemoradiation or chemotherapy. Okay. In terms of the actual histological makeup of the tumor or histological differentiation, basically there's three types that you should be looking at: the adenocarcinoma, mucinous carcinoma, and the signet ring cell carcinoma. And generally you'll find that the tumors on the right side actually tend to present more with mucinous and signet ring cell tumors, and therefore tend to be also more aggressive. So they may actually present earlier, but actually be more aggressive and have a poorer prognosis in the long term. It's also important to understand the underlying sort of pathophysiology or etiology of the actual uh, colorectal tumors. And there's basically many different pathways that have been proposed. I think the two main pathways that have been around for a long time, talking about the chromosomal instability pathway and the microsatellite instability pathway. So the chromosomal instability pathway is basically talking about your traditional uh, adenoma carcinoma sequence in the setting of a polyp. So typically like what you would find in a patient with FAP, for example. So they develop adenomatous polyp and that progresses to become a cancer. And there's often some association with a KRAS mutation. So that's chromosomal instability. Then microsatellite instability is basically talking about right-sided cancers and basically talking about problems with the mismatch repair gene. And because of that mismatch in that gene not being active, patients getting a problem with repairing of the cells and therefore getting a cancer on that basis. So it's important for us to understand that one is present on one side and the other on the other side. Other things that you need to know about is your serrated adenoma. So there are two other pathways you need to read up on and be familiar with. Also, in terms of inherited cancer, the two common ones we talk about is obviously FAP, where you have obviously a dominant mutation that's basically going to definitely lead to that patient having a cancer at some stage in their life. Whereas Lynch syndrome, obviously the penetrance is not 100%. And generally they will develop a malignancy in a certain proportion of the patient. All right. So I think that's this theory, and you can read up a little bit on that, both of those, and understand that basically I think you should have a consistent approach to polyps and group that together with your inherited cancer syndrome. In terms of investigations for colorectal cancer, so it depends on your setting, and often in South Africa, because we have scopes much more freely available than radiologists, we often end up doing probably colonoscopy or flexible sigmoidoscopy and biopsy as a first-line investigation. And we don't now do a lot of barium enemas or even CT colonography, which is a newer modality. In our setting, we actually basically do a colonoscopy and try and assess the entire colon on that basis. And that'll allow you to look for obviously synchronous lesions at the same sitting if you identify a tumor. So it's important to understand, yeah, that I think colonoscopy is probably going to be your investigation or definitive investigation at some stage, because it allows you to take a biopsy and then histologically confirm that this patient has a colorectal malignancy. So barium enema, as I said, you can do it and you can have your typical apple core lesions that present, but I say it depends on availability. Probably in the private sector, it might be much more freely available. CT colonography is a very good investigation and actually can tell you a lot. So it's probably as good as a colonoscopy, except you can't do a biopsy with it. But it can tell you whether there's obviously a malignant lesion present in terms of the actual contour of the lesion. The problem with it is it takes a long time to interpret. So it requires about an hour of the radiologist's time to analyze it. And maybe when software is introduced that can actually give you a report just on the basis of the CT that's done, then maybe that will be a better technique in the long term. And this was initially thought to be the next way to screen patients, but now it's obviously not a good modality. So once you confirm your diagnosis that this patient has a colorectal malignancy, the next step will be to do staging investigations. And traditionally, we will take the approach that you will do a CT chest, abdomen, and pelvis. And the abdominal CT is mainly to look for to see if the patient has basically liver metastases. So an ultrasound of the liver may give you an idea of this, but the sensitivity of the CT is much better, and I think definitely the appropriate investigation if it's available. CT of the chest may also show you or has a higher sensitivity for picking up lung metastases, but often we find that most of these lesions are too small, so the literature hasn't demonstrated that a CT chest truly has benefit. But if you're doing a CT of the abdomen, it's probably worthwhile to do a CT of the chest, abdomen, and pelvis at the same time. Chest X-ray is not very sensitive for lung metastases, but obviously, if you do not have CT scan available, this may provide an alternative, even though a poor alternative. In terms of the actual imaging of rectal tumors, I think for colonic tumors, generally, if there's no suspicion that there's a large mass, you don't necessarily need to use a CT to actually assess the actual tumor itself and whether it is resectable. Unless you suspect that it may be quite an advanced mass, then there's probably benefit in doing a CT scan. So for rectal tumors, the choice is between an transluminal ultrasound or an MRI. The transluminal ultrasounds are only for early lesions. So if you think the patient has a very early lesion and you're trying to distinguish between a T1 and T2 lesion, then only you do this. And I think the number of patients that we probably find is probably less than 10. So I think it's not commonly used in our setting, and patients present late for a variety of reasons, but probably more applicable with patients maybe even in the private sector presenting very early. MRI, so MRI basically is for those patients who you think have, as I said, more advanced lesions, so T3, T4 lesions. Okay, so basically the Mercury study and the Mercury 2 study have basically demonstrated that the diagnostic accuracy of MRI is far superior, and basically it showed that if you do an MRI, it will allow you to accurately assess whether this patient would benefit from neoadjuvant therapy or can be a candidate for surgical resection. So I think if you can do an MRI, it's probably the best investigation. I mean, in where I work in Greys Hospital, we do have an MRI scan, but the demand for it is so great that even though we have it available, we don't really use it routinely, and we select patients that we choose an MRI for. So I think practically it may be difficult to actually use the MRI as routine practice in our setting. I think if you can make it routine practice, it's definitely a better way. In the exam situation, you're definitely going to say MRI is your staging investigation of choice to assess regional extent of disease for a rectal cancer. So, and the evidence has shown definitely that's the way we should. So the important thing when you're doing an MRI is you need a good radiologist to actually do the MRI and to plan for the MRI, because as you can see in this first image here, it shows that the plane through which you take the rectum can be different. So it can be in the actual longitudinal axis, or it can be maybe in the incorrect axis that way. And then you can see there are two images here. So in this first one, it looks like that the tumor is actually invading into the prostate. But if you look at the second one, it actually shows that the tumor is actually completely free of the prostate. So it's important to have that orientation and for your radiologist actually to do the MRI properly so you can interpret the images properly. And you can see the MRI will actually show you the actual extent of the lesion itself, where it's invading into the sort of perirectal space and where it's involving any of the nodes in the mesorectum. So you can see there's probably one involved node in the mesorectum there. You can just on the size of it, you can say it's probably involved. There's another MRI from a male patient. You can see there's your seminal vesicles there on that side. And basically, you want to demonstrate that the tumor is not basically breaching this, this area here and making it a T4 tumor. But if you look at this tumor, it's actually involving, basically that's your mesorectum, or that's a fat of the mesorectum itself. There's your tumor there. You can see it's actually breached your muscular layer. And so you can see that there's your mucosa, which is a little bit lighter, and there's your muscular layer, so your muscularis propria. So the tumor has actually breached your muscularis propria, and definitely it's a T3 tumor. But and in the ideal setting, you would offer neoadjuvant for this, but you can probably undertake surgery and still get adequate margin. So in terms of discussing the cancers itself, I'm going to separate out colon and rectal cancer, especially since, as I said earlier, colon cancer is basically, you would not investigate as thoroughly because most of the time you are going to offer these patients surgical intervention. And only if there's metastatic colorectal cancer, then you would consider whether you're going to give these patients chemotherapy, or you're going to plan whether you're going to, what you're going to do with the metastatic disease. So the primary therapy is operative. But in terms of the principles of the operation, you initially want to explore the patient and basically assess if your extent of disease is actually accurate. These principles are what they do overseas, so they will do intraoperative hepatic ultrasound to stage the tumor better. From our perspective, we will do a bimanual palpation of the liver just to ensure that there's no liver metastases that you may have missed on your staging investigation. In terms of managing the cancer, you want to remove the entire cancer with an adequate proximal margin. So we're aiming for 10 centimeter proximal margin and a 5 centimeter distal margin. With the advent of the new concept of CME, that distal margin is now thought to be 10 centimeters also, but we'll talk about that in a while. So you want to basically resect adequate volume of that bowel. So if there is spread along the submucosal plane itself, then you can actually make sure you've completely resected the tumor. Furthermore, I think, and this is probably the most important part of colon cancer surgery, is that you need to remove enough of the colonic mesentery. And I think if you've done a resection for a colon cancer and it comes back only showing a few lymph nodes, it's probably because you haven't done an adequate resection of the mesentery, or the patients had neoadjuvant therapy of some sort. So the principle of resection, what's basically been spoken about, is that you should try and basically remove the pedicle of that, or the entire pedicle of the draining lymphatics and lymph nodes. If you have an advanced tumor, so if you've got a T4 tumor, for colon cancer, you can still perform surgery safely. So you can resect other organs. For example, if it's a tumor in the splenic flexure and involving the spleen, you can do a splenectomy. Involving the tail of pancreas, you can do a distal pancreatectomy. So you can resect other organs. Your kidney might be a bit more rate limiting. So a nephrectomy is called radical. So if you have proper consent and the patient's a suitable candidate, you can even go ahead and do that. In terms of what resections you do, it depends whether it's a right-sided colon transverse tumor or left-sided colon tumor. So normally you would do a right hemicolectomy for tumors basically involving the cecum and ascending colon. Once your tumor starts coming to the hepatic flexure, then you want to do an extended right hemicolectomy. You probably are asking, what do I mean by this? So that's why I discussed the anatomy first. So for a right hemicolectomy, what you're doing is you will take your right colic artery at its origin, as close to the origin as possible, and you would take your right marginal branch of your middle colic and you leave the left marginal branch. If you're doing a extended right hemicolectomy, then you take the left also. So you take the middle colic artery at its origin in that setting. Okay, so for a left hemicolectomy, it's quite simple. So you will obviously take the left colon colic artery at its origin, but you preserve your inferior mesenteric and superior rectum. It's important to remember that because that blood supply needs to be preserved so that when you do anastomosis of the rectum, there's adequate blood flow there. Well, you can do a transverse colectomy. It's not a common operation, and generally it'll only be in a setting where the tumor is in the middle of the transverse colon. And in that setting, you would basically take your blood vessel, middle colic artery at its origin. Okay. The new concept we talk about now is CME, or complete mesocolic excision. And it's basically excision of the colon with its entire mesentery. And it's not a simple procedure to do, but you'll need to be aware of it because you may be asked about this in the exam. And basically, if you look at the colon from an embryological perspective, you understand the colon and the mesocolon basically is covered by what we call visceral fascia. And if you dissect in that plane, it's quite safe surgery. The danger is that you need to dissect in the mesentery of the actual colon and small bowel. And the danger is you could injure basically your main feeding vessel, like your superior mesenteric artery, for example, or superior mesenteric vein. And that may pose the danger of causing infarction to a large amount of small bowel. So say it's not to be done by anybody, and I think this concept needs to be done by someone who's specializing in colorectal surgery. And it's still in the stage where it's, even though it's being proposed and being practiced a lot in Japan and other countries in the first world, I think in South Africa it's still finding its niche and when it should be done. It's proven that it gives you better outcomes in the long term with lower recurrence rates. But definitely it's quite successful if you can do it safely. This is just a diagrammatic representation of the lymph node station. So D1 is basically lymph nodes that are present right next to the colon, basically where your marginal artery of Drummond is running. And D2 is between that and the origin of the vessel. And this is probably where you would do your standard resection. And that's the plane where we've been dissecting. Now for a CME, or what the Japanese call a G3 resection, you're basically doing what they call the central vein ligation. So you're taking your vein at the point where it's entering the vessel that it's draining into. Okay, and as I said, the danger is that you may injure the superior mesenteric vein. Okay, so any questions regarding the surgery for now for colon cancer?
Any questions, please put up your hands.
Okay, so we'll move on since I think there's not many questions. So
sorry, just a second there. Sorry, there are one or two questions.
Okay.
Dr. Khan?
Hi, Mr. Govindasamy. I just had a question regarding central vein ligation. I'm not sure, maybe if you explained it, but I just didn't understand it clearly. Do we consider it as a step within the complete mesocolic excision? And is there something specific that obviously needs to be mentioned regarding it, particularly for the exam?
Maybe it's basically part of complete mesocolic excision. So the principle is you do a central vein ligation. So as you know, the lymph nodes are found actually around not your arteries, but your veins per se, because of the venous drainage. So when you ligate the vein, you want to get basically to the origin of the vein, or where the vein is actually draining into the superior mesenteric vein itself, and try and ligate it at that point. So, so yeah, you basically trying to do a central vein ligation as the principle of the surgery. And then if you read the literature, the Japanese literature talk about doing a D3 lymph node dissection, and the Western literature talks about doing a central vein ligation. It's effectively the same principle, and it's the principle of doing a complete mesocolic excision.
Thank you for
And
that.
I don't think many surgeons are doing it routinely in South Africa, or even enthusiasts in it. I think we're doing it occasionally. So I think it's something that we will hear more about as time goes. It's like when laparoscopic surgery first started, and then as it developed here. So it's still in the developmental phase, I think. It's important for you to understand the principle of it. And basically this diagram here gives you the idea. So your normal dissection there, or you're ligating the vessel there, but now you're going one level lower, and you're going there. So obviously it's going to improve your lymph node healed. And as I said, the danger is that you may damage supply or blood supply to the colon itself, to the small body itself.
Okay, Dr. Raymond Bawi had a question.
Yes. Sorry, just wanted to find out, can you hear me?
Yes, I can hear you. Go ahead.
Yes. Okay, so I just wanted to find out what will be your surgical approach of choice for a splenic flexure tumor, right?
For splenic
Versus
flexure tumor, you'd basically do a left hemicolectomy.
left hemicolectomy.
Left hemicolectomy.
Okay.
So you want to try and preserve your middle colic artery. So if you have to sacrifice your left marginal branch, you probably can do that. But the principle is that you're going to do a left hemicolectomy.
Yeah. I think the reason why I'm asking, I think I had a presentation where the concern was if you have to do your anastomosis, some people have advocated that you do an extended right so that your ileum is very mobile, which you can actually move across to your colon and do an ileocolic anastomosis. Unlike if you do a left hemicolectomy, you probably would have some difficulty mobilizing your transverse colon, as well as possibly taking down your hepatic flexure just to get down to your distal stem.
Yeah, I think if you do a left hemicolectomy, and you should be able to get down, provided you mobilize your middle sort of colic artery adequately, you get down to the base. But you're right, if you have a problem doing that, then you can look at, but you see that the important thing is you have to take actually your superior marginal branch of your left colic artery, because that's also draining the tumor as it comes up to the splenic flexure. So I'll say the principle is you should do a left hemicolectomy. But if you need to change that, then it means you have to do an extended right, plus you have to remove part of the left colon. So it's not just an extended right hemicolectomy. It's actually doing a left and right hemicolectomy in that setting. Okay. Any other questions?
No, there's no one's hand up. You can carry on.
Okay, so we'll move on. So basically, patients that have selected patients that have stage 2 disease, and all patients that have stage 3 and 4 disease will get adjuvant chemotherapy. And the standard adjuvant chemotherapy that we've been using for a long time is basically what a lot of it came actually in sort of the early 80s and 90s, is basically using a regime with 5-fluorouracil. And initially we used a drug called levamisole with it, and there was some degree of efficacy. But once they added or changed the agent to leucovorin or what's folinic acid, found that it was very effective in managing sort of especially lymph node metastases, but even metastatic disease to the liver and lung. So that's what we would use for as adjuvant chemotherapy. If you have metastatic disease, then you're going to have to add oxaliplatin to that, or irinotecan. It depends on the setting you're using it and what the patient chooses, and knowing full well that oxaliplatin does carry the side effect of significant peripheral neuropathy. That's a big problem, and patients need to be aware of that. Okay. But what do I mean by selected stage 2? So basically, tumors that have poor prognostic features. So maybe a tumor that's got it's poorly differentiated from a histological perspective. Is there's lymphovascular invasion, or basically if the patient presents as an emergency with bowel obstruction or a perforated tumor, all of those patients, even with stage 2 disease, will get chemotherapy. So we'll move on to cancer. I think we're definitely running out of time a little bit. But basically for rectal cancer, in terms of your therapeutic options, primary surgery is for T1 and T2 lesions. And for T1 lesions, basically you can do a local procedure, either what we call transanal endoscopic operations or transanal endoscopic microsurgery. So there's two terms for it because there's two companies that produces different devices to do the surgery. But the principle is quite simple. Basically, you put a big proctoscope into the rectum, you inflate the rectum with air, and then you use your laparoscopic telescope to visualize the lesion and excise the lesion using some sort of energy device. And you can basically, because the rectum is extraperitoneal, for a lot of the lower lesions, you can actually even do a full thickness excision safely and not even repair the area and get a favorable outcome. So for T1 lesions, definitely local excision is a good option. The problem with doing a local excision is that you're not removing the lymphatic drainage of that area. So if the T1 lesion turns out to be actually a T2 lesion, and that basically is spreading beyond the submucosa, that means there's a risk of it actually having lymphatic spread. So that's a difficult situation where you have to either evaluate the patient before, if you suspect it's advanced, or if you find out later whether you need to go back and do maybe a more extensive procedure on the patient. And sometimes maybe even an AP resection. Or the alternative is whether you're going to give the patient some sort of chemoradiotherapy for it. Okay. So for T3 and T4 lesions, you would do neoadjuvant chemoradiation. For T2 lesions, you'd basically offer them surgical resection up front. And this should actually form the bulk of your tumors that you do see in the rectum. So for metastatic disease, basically, these patients will be treated with chemotherapy. And in terms of managing the local disease, whether you do surgery or whether you do palliative radiotherapy, or whether you even treat the patient as a curative patient, it depends on the setting and the extent of liver metastasis. It's a whole topic on its own, so we're not going to go into detail on it. And we can have another meeting probably to discuss that, a separate meeting, because we have to talk a lot about the liver in that setting, and it's much more detailed. So in terms of radiotherapy, the radiotherapy for rectal cancer was basically a big advance in the treatment of rectal cancer. And the first study that basically promoted the use of radiotherapy was a study done by the Dutch Colorectal Cancer Group. And they basically used what we know as short course radiotherapy. So they gave 5 grays over a 5-day period, and they operated after 10 days. And by doing that, they managed to reduce the local recurrence to 2.4%, whereas the group that didn't have radiotherapy had a recurrence of 8.2%. So obviously it's quite obvious that this is a big change in outcome. Their study was, so they published it in 2001. In 2002, the Swedish colorectal cancer group also published a similar study and showed a similar reduction in recurrence of the tumor. So these are two important articles you should be aware of, and sort of landmark articles in the use of radiotherapy for resectable rectal cancer. So the Germans decided to take it a little bit further. So they wanted to look at, you're giving radiotherapy or chemoradiotherapy, should you give it before or should you give it after operating on these patients? So basically they conducted a study where they looked at preoperative versus postoperative. And this was published in 2004. So, but they didn't use short course radiotherapy. So they use what we know as long course radiotherapy. So basically the patient has 1.5 Greys given every 5 days. Every day over over 5 days for each week and over a 5-week period. And basically, the patient gets a total of 50.4 Greys at the end of it. And then they have chemotherapy given on the first week and the 5th week of their treatment. And these patients in the original study had surgery at 6 weeks after completion of your radiotherapy. And they demonstrated that the recurrence rates were 6% in the preoperative chemoradiotherapy versus 13% in the postoperative treatment group. So another significant difference. And obviously, I think we then knew that the way you should give chemoradiation, ideally for advanced tumors, is in the preoperative setting. The other important thing to know about this trial is that they only treated patients that were T3 and T4. So these were advanced tumors that they were dealing with, not early tumors, whereas the previous studies spoke more, dealt more with tumors of all grades. So in terms of laparoscopic surgery, obviously,
laparoscopic. Govindasamy, can I just interrupt you? There's just a question from
I can go back there.
Registrar, Dr. Alkilani. Do you want to? Can you put on your mic, Dr. Alkilani?
Good evening. Thanks for giving me the opportunity to ask questions. Yeah, thanks, Mr. Govindasamy. I would like to ask about the role of brachytherapy. Is there any superiority of using brachytherapy, brachyradiotherapy over the external beam radiotherapy?
What do you mean by brachytherapy? You mean endoluminal therapy?
Yes, endoluminal, yes.
Okay, no, it has no role in rectal cancer, because the problem with rectal cancer is you want to reduce your CRM, so your circumferential resection margin. So you want to treat that. You don't want to treat the lumen, but you want to treat the outside. So the best way it is actually given, as you say, with external beam. But I mean, radiotherapy has advanced so much these days that you can actually concentrate the radiotherapy where you want to give it. So you can even choose, I want to cover 2 millimeters of the prostate, for example, when I give this radiotherapy. So it's very specific. So because of the advances in radiotherapy and the technology itself, it's very precise. So I don't think there's any role at all for brachytherapy in this setting. So it's unlike a soft gel CA where it does have a role. And there it's probably more for palliative. Okay.
Thanks, Mr. Govindasamy.
Okay, so with regard to laparoscopic surgery, so these are the landmark sort of articles. Initially, the COST trial from America, and then the classic trial and the color trial, and even the color 2, which was an extension of the original color trial. Basically, all of them supported that laparoscopic surgery was equivalent to open surgery in terms of oncological outcome. So basically, your 5-year survival and your disease-free survival was equivalent. So, and that's what those studies tried to demonstrate, and they demonstrated it successfully. So even the recent trial in 2017 confirmed that. And if you look at their overall survival, it's even getting into the 90s, which is excellent results. You can see in the last trial here, overall survival is quite excellent. Obviously, they're very specialized in terms of what they're doing, but yeah, so laparoscopic surgery has an equivalent outcome. In terms of, is it the best option? And after this, there's been a lot of research on laparoscopic colorectal surgery. And lots of people were saying that, this would be the new normal, the new routine. But there are some newer studies which actually have taken a lot of the enthusiasts for laparoscopic surgery by surprise. And the two trials that basically I'm talking about is the ACOSOG Z6051 trial, which was done in Dallas in America, and the ALACART trial, which was done in Australia. Both of them, their primary endpoint was actually to show that laparoscopic surgery was equivalent in terms of successful resection rates. And that was basically looking at the margins and getting a good total mesorectal excision and having a good circumferential resection margin. But it didn't demonstrate this. So basically, it was it failed to prove that it was non-inferior, basically. So it was inferior in terms of the outcomes for both those studies. So I think it's basically means that the researchers will have to go back to the drawing board and look at this. And so for now, laparoscopic surgery remains for those people that probably are experts in it, but it should not be routine practice. So your first choice should probably still be an open procedure, especially in our setting where we deal with more advanced cancers and the risk of getting a positive circumferential resection margin is probably higher. So definitely, yes, an open surgery will probably make sure that you actually adequately resect the tumor. The one difficulty, especially with laparoscopic surgery, is where you have to do an anastomosis, and to actually staple the behind a bulky tumor can be very difficult. So what are the surgical options in terms of not a local excision, but for rectal cancer? And basically, I've only put two options here because these are the two options that have proven themselves. So an anterior resection and an AP resection. So maybe we can start with an anterior resection. Can someone quickly take us through an anterior resection? And it needs to be very summarized. Can I get any volunteers?
Hands up, anyone who's willing to volunteer? Dr. Wayne? Just find him.
Hi there, can you hear me?
Yes, we can hear you. Go ahead. Just outline the key principles, please, Howard.
Sure. So obviously either laparoscopic or open. Resection is started obviously intra-abdominally and starts with mobilization of the distal, left colon. Wherever you choose to start obviously will depend on how proximal your tumor is. But it's going to be mobilization of the left colon. You spoke about at the line of Tolt and then in Tolt's fascia itself. Obviously, our aim is complete mesorectal excision. So we'd resect in that, dissect rather in that, in Tolt's fascia to completely excise that mesorectum as well. Obviously, one needs to take care to avoid underlying vessels and ureter in particular. And then extend distally to until you got beyond the tumor. So for the purposes of an anterior resection, obviously we're not excising the sphincter complex, and we're looking for a distal margin of 5 centimeters, as you mentioned earlier, although more might be more appropriate again, like you mentioned. So once beyond the tumor at 5 centimeters, deal with the left colic artery and vein, and then you're going to do your division of the colon. Usually in the setting of an anterior section, you're going to be doing an anastomosis as well. So once the specimen's delivered, then perform your anastomosis. That will obviously require some degree of proximal mobilization to achieve that, and then anastomose in whatever fashion is chosen. So I'm being very brief for the sake of time, but okay.
I think that's good, Howard. And I actually didn't put a lot of detail or even a slide up on the steps, because I want everyone that's attending basically to go and look at this. And I think in your mind, you need to get the steps correctly. I will go through it very, very briefly again. Basically, the principle behind it is you might mobilize the left colon. You might start with mesenteric mobilization. So it depends whether you're doing it open or laparoscopic. But the principle is basically you get into Tal's fascia, or maybe a little bit more posterior to that, and you get underneath your blood supply to the rectum. So basically, you mobilize the superior rectal artery or up to the inferior mesenteric artery. And like Howard said, that you need to divide basically inferior mesenteric, superior rectal, and left colic. And then your next step is to mobilize that left colon. So like I said earlier, the principle is to mobilize the colon laterally, but you also find that plane behind the colonic mesentery, between gerotas and the colonic mesentery. It's important that it must be completely free there, because that's where it's going to hold you back, basically from bringing it down into the pelvis. And you mobilize the splenic flexure, so you go beyond your splenic flexure and you go into part of the transverse colon. You also might have to take it off the pancreas or the edge of the pancreas a little bit. And you want basically that splenic flexure to be so mobile that it actually can come completely into the pelvis. And so I think one of the principles, and when we do laparoscopic surgery, the way we do it is because you remove your specimen through a fanal seal incision, then invariably that makes sure you actually your specimen, your colon can get into the pelvis, because to remove the specimen you have to bring it out through it. In terms of preserving structures, like you said, ureter is key, gonadal vessels is important. Also remember there's a lot of nerves just anterior to the aorta. You get your superior plexus, or your superior hypogastric plexus of nerves there, and you need to preserve that. You need to make sure both your hypogastric nerves are preserved as they go into the pelvis. And then further down, just to mention it now, is your inferior hypogastric plexus and your nervi erigentes, your parasympathetics, basically from S2, 3, and 4. So once you get that plane, you need to find basically your TME plane. And the TME plane is easy to understand. It's basically a plane around the fascia propria of the rectum, so that fascia propria is intact. And ideally it should be smooth with no breaches, and it should be smooth and shiny. And posteriorly you'll get your Valdes fascia, anteriorly your Denon Valdes fascia. And then laterally you get basically the fascia propria of your rectum. Important to understand that posteriorly there's two fascial planes. There's your presacral fascia and your Valdes fascia, which is anterior to that. So you should never see any blood vessels posteriorly, and that means you're too deep. That means you're in the presacral plane. And then you need to come a little bit more anterior. The important structures you need to preserve laterally also is your ureters, so especially on the left-hand side. And as you get lower down, you should identify your seminal vesicles and your prostate anteriorly. And then in terms of your anastomosis, usually going to be a stable anastomosis, and you probably aiming to take your entire mesorectum in the setting to perform the surgery. Lower is actually safer, because then the blood supply that's coming from the bottom is actually better. It's important to remember that. And because especially your middle colic artery is not consistently pressed. And then your anastomosis will be angled in the proximal side, stapled from the bottom, and basically anastomosed together. Any questions regarding that? Okay, the difference with the AP resection is basically you're going to take out the anus. And in terms of how you perform it, I routinely do it prone. So I actually turn my patient over and do it with the patient prone. It can be done obviously traditionally and with at the same time as the top mobilization being done. But I believe you get a better view if your patient is prone. So using the same technique as the extra levator AP, but just position the patient prone and not taking as much of the levator ani, but resecting the tumor, and allows for better closure, safer closure. And basically the principle is you dissect around the anal sphincter, entire anal sphincter. You follow the rectum and the plane around the rectum and making sure that you basically get around the specimen completely and try and not sort of narrow your specimens in as you get to the levator, and you take a little bit of the levator. Anteriorly, make sure in the male that you do not injure the urethra, do not injure the prostate. In a female, basically the vagina. Okay. But please go and look into this, and if you have any questions, you can consult me independently about it.
Thanks, Dr. Govindasamy. I did see a hand up. I think was it Dr. Juma? Yes. Question.
Hi, Mr. Govindasamy. Thanks for the presentation. I just want to ask a quick question. What would be your cutoff for offering a patient an anterior section? Just to clarify, what would you define as adequate margins? And one more question on the radiotherapy. When do you think is the best time to offer a patient surgery post neoadjuvant radiotherapy? Thank you.
Okay, so regarding the first question, basically a lot of people talk about the distance that when you should do radiotherapy versus when you should do an AP resection versus an anterior resection. Someone will say, oh no, it's 8 centimeters, no, we can get away, we can do an anterior. There's no absolute distance. The only way you will know is when you're doing the surgery itself. So you're going to mobilize the tumor and see if you can get safely below it, and that you can get a staple across it, or you can close it safely if you're using a suture to facilitate an anastomosis. If you can do that safely, then you know you can do an anterior resection. So it leads us to the question, what's an adequate margin? So basically an adequate margin is probably even a 1 millimeter margin from the tumor, that is. But having said that, you do not aim for a 1 millimeter margin. When you're going in, you plan to do a 2 to 5 centimeter margin. If you've got a tumor with poor prognostic features like mucinous tumors, signet ring cell tumors, or poorly differentiated tumors, then you aim for a 5 centimeter margin. If it's well differentiated, moderately differentiated, you probably can aim for a 2 centimeter margin. And doing that, you'll find you get an adequate margin. So you should not try and sacrifice your resection margin to try and preserve the sphincter. You must do the best oncological operation first. And if then you manage to save the sphincter, it's a good. So hopefully that answers that part of the question. Sorry, your second question, just remind me again.
When is the best time to offer?
Okay, in terms of surgery, traditionally it was 6 weeks. Now a lot of literature supports 8 weeks, and some people even 10 and 12 weeks after radiotherapy. I will do it at 8 weeks after radiotherapy. So if you're using long course and short course, so the recent studies on short course radiotherapy, that's 5 Greys over 5 days, show that you can safely operate at either 4 weeks to 8 weeks after completing the radiotherapy. So that may be the best option for us in the public sector, to use short course and operate at 4 or 8 weeks. And the evidence supports that now. So that sort of radiotherapy is equivalent to long course. So basically giving it over such a long period and then operating at the same duration, basically. So in exam, I would say 8 weeks, even though some people are doing it at 10 and 12 weeks. I think it's a balance between making sure the radiotherapy has worked, so it's given it adequate time, versus it causing too much fibrosis. Because if you wait too long, it may cause a lot of fibrosis and make the surgery technically difficult. Any other questions?
Dr. Khan?
Hi, thanks for the presentation, Mr. Govindasamy. I just had a question. If you've got a patient who's got a T3 or T4 tumor, and you provide this patient with neoadjuvant therapy, and when you reevaluate the patient or you restage the patient, you find that there's complete response to the chemoradiotherapy, and there's no lesion identifiable on the colonoscopy or on imaging. Would you just surveil this patient, or would you consider surgery because of the concern that there may still be microscopic disease?
I think in terms of having a complete clinical response, so there's two entities you're talking about: complete clinical response versus complete pathological response. So complete clinical response is where there's no apparent tumor. So if you have a fairly advanced, sort of fairly early tumor, even though it's advanced, you'd invariably mark the tumor. So you know where the tumor was. So ideally, if you find there's no tumor, then you must give the option to the patient. So the patient will decide what's the best option in the setting. Because you cannot guarantee that patient that the patient had a complete pathological response, even though there's a complete clinical response, that the tumor seems to be gone. But maybe if you do an AP resection or anterior resection, you might find that actually there's still a residual tumor there. Trying to sample the area hasn't really been supported in the studies that they've tried to do it. So I think basically between you and the patient, you have a discussion, you decide what's the best option. I think there are some people who will say, no, we shouldn't be operating on these patients and doing an unnecessary operation. But it's to make sure that patient doesn't have a recurrence, because once you have a recurrence, then the risk of the patient having a more advanced tumor is higher, and the outcomes are poorer, definitely. I know Habagama showed very good results in her studies. None of her sort of outcomes have been replicated by any of the studies done elsewhere. So obviously the way she did it worked for her in her setting. It might be even the profile of patients, the way she conducted the study itself, her own dedication and things like that. So I don't think we can rely on that in our setting. And at the end of the day, you will make a joint decision together with the patient. Yeah. Thank you.
A question from Dr. Alkilani.
Thanks, Mr. Naidu. In terms of the patient that came, like he's young patient, like 35, 40 years, and he comes with rectal cancer. There is any rule for genetic counseling for like these patients and their families, or do we have any screening or surveillance?
I think the most important thing is when you're talking about genetic testing and screening, I would say 35 is not so young. So if you have a younger patient, let's say anyone under 30 probably, then you would look at whether they have some genetic risk and then whether their family have a genetic risk. Alternatively, if you do get someone who's in their 30s and they have a significant family history of other cancers, then you know that patient probably has a higher risk of having some inherited cancer. So I think those two factors put together, you can definitely do genetic testing. Unfortunately, none of the testing is done here, so we can we'll have to take the samples and then send it up to Joburg to get tested. So the tests are not actually done in Abertuli at present. They do go up to Joburg to get tested. But it's possible to do them, and I think the only way to know whether you should do the testing is you have to go into a proper history for these patients. So you have to find out about their family history, extended family, and all of that. Okay.
Thanks, Mr. Govindasamy.
Okay, don't seem to be any more questions. And I think we're past 8 o'clock. So I'd like to thank Dr. Govindasamy for an excellent presentation that I really enjoyed myself. The review of the anatomy was excellent. Thanks very much for that. To all the attendees, as you leave the meeting, there is a little poll, a little questionnaire that I've set up. If you can please take a minute to answer it, I'd appreciate it very much. Just to remind you, there is an ASSA registrar tutorial tomorrow at 2 to 4 p.m. I did a poll. There are some people that don't have the links. I will make sure those are sent out again. Then there's the weekly UKZN Surgery Forum meeting on Friday morning. You should log in at about 7 for 7:15. And then on the Saturday morning, the surgery seminar, log in at about 7:30 for 7:45. I will send out all the links for that. And the seminar topic this week is advanced breast cancer. Thank you very much for everyone who attended, and a special thanks for Dr. Govindasamy. Good night, everyone.
Thank you.
Thank you.